कौन सा?
चलो और स्टार्ट उसको फॉरवर्ड करने का ये इसके ऊपर सर
डाउन.
Hello, good morning students. Yesterday we have considered acute pancreatitis. Now last time we have considered acute pancreatitis is one of the most common conditions, most painful condition, but that condition is reversible. Per se, in first week in early acute, no morphological changes appear. But as against that, when you consider chronic pancreatitis, that is CP, this condition is a condition of persistent inflammation and irreversible fibrosis. And what is happening? Atrophy of the pancreatic parenchyma. So the basic difference, that condition is acute where everything is reversible. Once you go to chronic pancreatitis, the conditions are becoming irreversible. But one thing everybody must remember, acute pancreatitis do not go into chronic pancreatitis. These two are separate conditions. Their pathology is separate. Many times even etiology is separate. Presentation separate, management separate. So what is this chronic pancreatitis? This condition is primarily a very severe painful condition with endocrine and exocrine insufficiency of pancreas. Do not confuse. Endocrine, exocrine are functions of pancreas not affected in acute pancreatitis. And in chronic pancreatitis, what happens? Most of the cases who has got exocrine insufficiency, they will precede endocrine manifestations by many years. That means what is happening here? Primarily, this disease is of exocrine insufficiency. The pancreas has got two major types. Exocrine is 95% and only 5% is endocrine. So, obviously, being 95%, morphological changes affect the exocrine insufficiency. That means most of the clinical presentations of a chronic pancreatitis are related to exocrine insufficiency. And now what is happening? The beta cell produce insulin. Up to 90% of the beta cells has to be lost before clinical diabetes develops. That means diabetes mellitus is a late manifestation of chronic pancreatitis. Regarding the etiology, there is a beautiful system which is called as Tiger O system. We'll consider that. So always remember, most common cause for chronic pancreatitis is heavy alcohol consumption, not short duration of alcohol. It is a heavy alcohol consumption. In 70 to 80%, this is the most important cause. And to add to the fear, it is a smoking. Smoking increases the risk but is not a primary cause. Etiologically, other causes which are going to help: duct obstruction, trauma is very important cause, and pancreas division. Last time we have considered this, it is a congenital commonest anomaly of pancreas. Related hypertriglyceridemia, autoimmune, hereditary, they are all going to account for 10% of cases. But 70 to 80% of chronic pancreatitis are mainly due to heavy alcohol consumption. In acute pancreatitis, more than 70 to 20% due to gallbladder disease. Here it is alcohol. Always remember the basic difference in acute and chronic pancreatitis. So, how does it manifest? Chronic pancreatitis can be chronic relapsing pancreatitis. The etiology is different. Here, why so many classes done? In chronic relapsing pancreatitis, it is primarily etiogenic. That means there is no definite cause which can be found. So it is related to hereditary, congenital, or what you call as a familial. MBN1, MBN2 syndrome, chronic relapsing pancreatitis. That means in between the two attacks, the patient is normal. Second is purely persistent chronic pancreatitis. The causation here is non-calcifying pancreatitis where there can be other reason as pressure from somewhere, and calcifying it is mainly into the pancreas itself. So what are the causes in pancreas itself? First, in the duct, commonest is stone in the pancreatic duct, not in the bile duct. Stone in the pancreatic duct. Stone in the common bile duct will cause what? Acute pancreatitis. So this is the difference between the duct. And many times this pancreatitis can be into the parenchyma itself. That means affecting the exocrine glands. So remember, chronic pancreatitis is more common in males, and in our country it is more common in South India, mainly Kerala. As they say, the consumption of tapioca is one of the primary cause for chronic pancreatitis. So this all you should know while writing the answer. So etiology in short, remember alcohol, stone, malnutrition, hyperparathyroidism, hereditary, idiopathic means by mutation, trauma, congenital anomaly, cystic fibrosis, autoimmune pancreatitis, and hyperlipidemia, that is increase in soluble fats. So this is a common etiology. So how the etiology is classified? By Tiger O system. These are the etiological classification of risk factors. Risk factors for chronic pancreatitis. They were classified in those are 1. What are they? T stands for toxic metabolite. That means any toxic metabolite derived from any source. Commonest are alcohol, tobacco, dietary, and drugs. Metabolic is hypercalcemia, hyperlipidemia, and lipase deficiency. Lipase plays a major role in exocrine function. I stands for idiopathic. This is like tropical causes. Means what we thought in Kerala. It is a tropical cause. G for general, that means mutations. Genetic mutations, pink mutation is very common cause for chronic pancreatitis. A stands for autoimmune diseases like Crohn's disease. Crohn's disease is always an autoimmune disease. Crohn's primarily affects small intestine. Also, it affects the pancreas. It also affects ulcerative colitis. And R stands for recurrent radiotherapy. And I is very important. It is ischemia. Why does ischemia occur? Ischemia occurs because of inadequate blood supply to the pancreas due to edema. Among that, O is obstruction. Where does the obstruction come from? From the anatomical deformities like pancreas divisum, annular pancreas, stenosis, duodenal obstruction, pancreatic stones, and choledococele. Choledococele occurs in CBD. This can give pressure over the pancreatic duct to cause chronic pancreatitis. So, even malignancy, tumor is obstructing duct, and most common cause is SOD, that is sphincter of OD dysfunction. That is a primary obstruction to pancreatic duct as well as common bile duct. Next comes, what is the commonest cause? It is alcohol. How does alcohol act? It reduces the pancreatic blood flow, and what it will affect? Cell viability and pancreatic ischemia. In Tiger we found ischemia is the commonest cause. So how does it occur? It is because of alcohol. Genetic predisposition, hereditary autosomal disorder, and mainly hereditary occurs in childhood. Unfortunately, very severe pain in childhood and which leads to coronary pancreatitis and unfortunately pancreatic cancer. So hereditary pancreatitis has got a comparatively bad prognosis. So how the whole things occur? This is called as a pathogenesis of chronic pancreatitis. There are different hypotheses. Don't bother about that. Primarily, this is oxidation, metabolism, toxic theory, and necrosis. Remember, toxicity, necrosis, and ischemia are the primary causes of chronic pancreatitis. Related to that, formation of obstruction by pancreatic stones. Genetically, there are different hypotheses, but mainly it is a heavy and prolonged alcohol use which will cause chronic pancreatitis, that is tropical pancreatitis endemic in Kerala. So, in short, what are the pathologies? First, focal necrosis, segmental diffuse necrosis, calcification, formation of ductal stones, and either stricture plus heavy dilatation of a pancreatic duct. Understand? So, this is we are going from etiology to pathological causes of chronic pancreatitis. First, etiology, second, etiology. This is how you have to write down. And then we'll go for how does it all pancreas affect. So, what are the spectrum? There can be early chronic pancreatitis, moderate, and late. The pain of the pancreatitis is so severe which does not respond to many of the analgesics. Has found out that the pain is of some different nature, and they have found this pain due to a pressure within a very sensitive ductal system and ischemic pain. The ischemic pain is very severe unless ischemia is reduced. Similar like acute myocardial infarction, acute mesenteric ischemia, acute bowel ischemia, acute strangulation. So that ischemia has to be relieved. And here main factor that ischemia affects the nerves. So nerve factor depending on the perineural sheath destruction by the toxins and ischemia is a major cause of irreducible intractable pain in chronic pancreatitis. So clinical features, remember in short, there is always a classic triad. The triad is called as DM stand for diabetic mellitus, pancreatic calcification on X-ray or USG, plus most important is steatorrhea, passing very heavy stools and loose stools. Well, not well formed, steatorrhea. This condition occurs because of exocrine deficiency. This is called as DPS. So, the most common presentation, if you are asked, you must say it is a pain in epigastric region in 80% of the patients. Rest comes afterwards. Pain is persistent, severe, and it is radiating to the back. Equally common condition, severe persistent pain radiating to the back, also occurs in one major condition, that is aortic aneurysms. Here the pain is due to retropancreatic nerves, chronic inflammation or dilatation. The pattern of pain is usually two types. Type A, short relapsing episode lasting for days to weeks. And fortunately for the patient, he has got a pain-free interval. Unlucky patients, type B pain, prolonged, severe, unrelenting pain. Even God cannot help them with this pain unless they undergo a major surgery. Here, the difference is the pain in acute pancreatitis is associated with a rise in amylase lipase level up to 5 times, even 10 times. But here, the amylase and lipase levels are not associated. So, amylase, lipase are not raised in cases of a chronic pancreatitis. So, why? Because exocrine function have come to halt. So there is no production of amylase or lipase. That is why patient is getting what? Steatorrhea. The digestion is majorly affected. So what happens in the end? In few patients, there is a gradual diminution in pain over years due to what is called a pancreatic burnout. That means nothing is left. All the exocrine and endocrine glands are destroyed, so there is no pain. That is the end stage of the disease. So, what is exocrine dysfunction? Again, remember diarrhea. Diarrhea is always a presentation. Asthenia, patient looks ill. Loss of muscle, that is a causing asthenia. Loss of weight, loss of appetite, and steatorrhea. Never forget, this is a cause for pancreatitis. Jaundice, it can be mild, and in few patients there can be palpable mass per abdomen. How the mass looks? It is above umbilicus, tender, nodular, hard, and it is palpable on deep palpation. This is not going to move with respiration because it is in no way connected with the diaphragm. Non-mobile and resonant and percussion. Why resonant? Not the mass. There are intestinal coils in front of the mass. So again repetition of the triad: pancreatic calcification, steatorrhea, and diabetes mellitus. This is a triad. But what has happened? This is found usually in only one third of the patient with chronic pancreatitis. So, commonest cause is pain associated with diarrhea and loss of weight. One must always suspect a pancreatic pathology. This sign is important for a clinical examination. This sign is called as Mallet-Guise sign. What is the sign indicates? Whenever patient sleeps on right knee chest position, what will happen in that position? All the bowels which are in front of a pancreas will be shifted to right. So what? You can directly palpate the pancreas and it will induce severe pain. This is Mallet-Guise sign. But always remember the bad thing, chronic pancreatitis can lead to carcinoma of pancreas. So, to sum up, what are the clinical presentation? There are different stages. Stage A, 85% common, recurrent acute episodic pain with weight loss. Weight loss is always primary for pancreatitis. Stage B, severe prolonged progressive pain with associated pancreatic functions also and formation of complications like pseudocyst and portal hypertension. This is a pressure which is over the splenic vein and the veins go from behind. That is a superior mesenteric vein. They will be under pressure and giving rise to portal hypertension. Stage C, severe exocrine and endocrine deficiency. Now the whole of the gland is totally destroyed. Then what? There will be less pain, but all deficiency will persist and patient may have complication like a pseudocyst or obstruction to the flow. That is stage A, stage B and stage C. Stage A is 85% common. So what is the differential diagnosis? For a chronic pancreatitis is carcinoma head of the pancreas and second is retroperitoneal tumors because in retroperitoneal tumors they can be very large and can present like carcinoma of the pancreas. This is always adenocarcinoma, adenolymphoma where there is a large mass. So coming to complications, patient has got pancreatitis, chronic pancreatitis. What will happen to him? The complications commonest is pseudocyst of pancreas. It is also complications of acute pancreatitis. Here, pancreatitis CVD structure. Common bile duct is structure due to edema of the pancreas. So CBD structure is an effect of pancreatitis, not the cause. Portal thrombosis, peptic ulcer, and above all, carcinoma of the pancreas. There can be pancreatic fistula, pancreatic fistula, pleural effusion, and pancreatic ascites. Will be one of the very common cause. Most common is pseudocyst, pancreatic ascites, and carcinoma. These are the common complications. Rest you may remember or you may not remember. So, how are you going to investigate? All the clinical signs are in favor of a chronic pancreatitis. So, investigation chart, this is all just to read and will emphasis on a specific investigation. Commonest is here, what is the first line? Serum amylase is not very useful. As we discussed, serum amylase is a sign of acute pancreatitis. Second is blood sugar. Even blood sugar is affected very late. So what is remaining? LFT and prothrombin time again late. So this you have to diagnose on investigation. So the investigation of choice again lies into three or four. First is ERCP, CT, MRCP, plain X-ray. This plain X-ray is beautiful for pancreatitis, which shows calcification of the pancreas is 65% of patients. This investigation should always be done because these patients are thin built. X-ray taking very easy, minimum costly, and calcification is the diagnostic sign of chronic pancreatitis. Other tests are oral glucose tolerance test and different. We'll just consider. So remember IOC. Last time I said IOC stands for what? Investigation of choice. IOC for chronic pancreatitis is ERCP, endoscopic retrograde cannulation of pancreas. Second IOC is pancreatic function test, not diabetes. Pancreatic function test, fecal fat estimation, because fat is maximum in stools, that is causing steatorrhea, and that estimate indicates that there is no amylase. Amylase is not secreted by the pancreas, and investigation is MRI. CT abdomen, MRCP is one of the good investigations, which is non-invasive. The choice also goes to EUS because you can take a FNAC from a suspected malignant site. Higher up the study, secretin cholecystokinin is the gold standard for assessing what? Pancreatic function. This is for MCQ. What is the gold standard for assessing function? Secretin cholecystokinin. What is investigation choice for chronic pancreatitis? It is ERCP. These are answers for MCQ. LFT, serum trypsinogen, stools shows exocrine insufficiency, and plain X-ray abdomen. So we have come to the conclusion that we are dealing with the case of chronic pancreatitis. So how are you going to act now? What you will do? What is the plan of management? There are mainly two. Why patient has come to us? For a severe pain and loss of weight, loss of body texture, and what you called as a typical loss of proteins from the body. This is a body texture. So first is control of pain, improvement in maldigestion, and nutritional management. These three are the aims of treatment. What patients want? Control of pain. He wants to improve his digestive system and he wants to improve his nutritional status. So 1, 2, 3. And also management of any complication patient has come with, like a pseudocyst. So these are his requirement. So these are the aims of treatment. How are you going to do that? First stand the conservative. Always remember, all the patient must be treated conservatively first, unless there is a malignancy. In malignancy, conservative treatment has no role, conservative surgery is different. As against CP, that means chronic pancreatitis, in acute pancreatitis, conservative treatment is mainstay of management. The primary management of acute pancreatitis is conservative. Here, it is not conservative. You can give a trial of conservative management. So, how are you going to try it? Avoid alcohol. So, avoiding the cause and avoiding the recurrent cause of chronic pancreatitis. So, one must avoid alcohol. Diet has to change as the fats, proteins are not going to be adjusted or assimilated. So, what you should do? Low fat, high protein, and high carbohydrate diet, because carbohydrate can be digested and food has to be small and more frequent. What you should do? Supplement the pancreatic enzyme because they have gone short. Everything, that means all nutrition has to be substituted, like vitamins, medium chain fatty acids, everything has to substitute it. So this is a higher enteral nutrition. In late cases, you manage TPN, that is total parental nutrition. First is this is high end enteral nutrition. What about pain? Pain formation by analgesics. Unfortunately, very major analgesics do not help. So it is a morphine. That means this is a analgesic very strong. Barbiturate analgesic doesn't help. This analgesic is usually morphine is the analgesic of choice. Second investigation or second management is a nerve block. It is a splanchnic pain. That means this pain is not a vagus related. It is parasympathetic. Splanchnic pain. So what you should go for? Blocking the celiac plexus. This is done these days in centers. So this is a major management. And PERT. What is this PERT stands for? Pancreatic enzyme replacement therapy. What is primarily lost? Pancreatic enzymes are not functioning. That is why all the steatoria weight loss is happening. So you have to give substitute for pancreatic enzyme. What are they? You have to give them associated amylase. Protease. Protease is one of the major content. And if it is given, the pain also will be reduced. So, but it is very much essential that it acts only in females or some specific causes. Associated drugs are like fluoxetine octreotide. Octreotide in this condition may or may not help. In acute pancreatitis, octreotide, that is somatostatin derivative, is giving a very good response. So these are many theories: mast cell directed therapies, antioxidant agents, AGF, they are all theoretical. Somatostatin analogs, rule is not clear. So again, complication pain is pancreatic ascites. So what you have to do? Repeated ascitic taps. Repeated ascitic tap will give some relief from the pain. About steatoria, it can be very easily controlled with the wonder drug commonly using proton pump inhibitor, that means pantoprazole, with 1,50,000 units of oral lipase and low fat diet. So this steatoria can be very easily controlled. Also, this steatoria can be controlled by rice tube aspiration. How it is happening? The PPI inhibits acid in stomach, so it prevents lipase from getting inactivated in stomach. What was happening initially? The stomach acid used to deactivate the lipase in stomach, so steatoria. First of all, low production of lipase and also whatever produced is lost. Second therapy, which is non-surgical, most commonly done now by the gastroenterologist, is endoscopic therapy in chronic pancreatitis. It is actually gold standard of the management for pain. Why? It is having a very low morbidity, very easily done by them by side viewing endoscope. What are the indications are? pain relief, ductal stone can be removed, ductal stricture can be dilated, a pseudocyst, if communicating, can be easily drained, pancreatic ascites can also be drained, fistula can be treated, and the pancreatic duct obstruction can be relieved and pseudocyst aspirated. So, the endoscopic therapy is here to stay and it is the mainstay in the management of all the pathologies of chronic pancreatitis. Similarly, the simplest minor papillary sphincterotomy. Remember, we discussed pancreas has got two ducts, duct of Warshing and duct of Santorini. Duct of Santorini is becoming major duct in few of the patient where the papilla is very small. That is called as a minor papilla. This papilla is proximal to the ampulla of water. So that sphincterotomy or dilatation of that will help in the drainage of pancreatic fluid and the pain due to tension will be relieved. Now going to surgery. Primary management is conservative where we are given drug management and endoscopy. Also ESWL, that is this ESWL and sometimes other conditions. So for surgery, indications for surgery. First is persisting pain is a main indication. What persisting? Not responding to conservative management. Second is severe malformation and any suspicion of a malignant transformation itself becomes indication for surgery. Pseudocyst complications, portal hypertension, biliary obstruction. Here, whenever the common bile duct is obstructed by the pancreas, here you have to go for release of a biliary obstruction. Pseudocyst, pancreatic ductal dilatation more than 7 millimeters. That means it is a severe, it has to be operated. Remember, the normal diameter of a pancreatic duct is less than 3 millimeters. Second is pancreatic fistula and ductal stenosis. We have considered aims of theory for management of conservative as well for objectives of surgery. What are the objectives? Primary is pain relief only when endotherapy has failed. Management of complications, and we have to be very sure that procedure selected is one which shows less morbidity and mortality, and quality of life, that is QOL, has to be preserved. So these are what they are showing in short. The mortality and morbidity of all the surgical procedures for pancreas itself is very high. So this is in short. So what are the surgical procedures in chronic pancreatitis? Remember the names only. There are basically two procedures. One is a drainage procedure, another is a resection procedure. In drainage, it is a Pusto procedure. In resection, it is Beggar's procedure. That is called as DPPHR, duodenal preserving pancreatic head resection. So these are resection and drainage. Drainage gives a temporary result, resection gives a permanent result. But drainage gives equally good result. Here there are so many modifications like that, but the commonest we are doing is what is called as a Beggar's procedure and sometimes modified Beggar's procedure. So what is the modification here? Is that you have to go for bypass. So this is limited to stale spleen preserving pancreatomy. All procedure we are trying to preserve the spleen. So primarily drainage procedure, resection procedure. The surgery itself has got a limitation. What is the limitation? The disease per se, we have considered morphologically, it is an irreversible procedure. And so the ductal damage and surgery cannot cure nor it can reverse the process completely. This procedure neither can be prevented or arrested by any surgery. But even after this modification procedure, risk of development of cancer continues. This is a major drawback. So, what are the benefits of surgery in relation to pain relief? It relieves intraductal, interstitial, and intracellular hypertension through the drainage procedure. The nerve entrap which causes severe pain can be released, and head of pancreas can be cored. This is a pacemaker phrase procedure to relieve pain. It is one of the commonly done procedure. But coming to conclusion of what? Resection is better than drainage procedure. Being what? It can prevent the development of cancer. So principles: pancreatic duct decompression, pancreatic resection, and now what we are doing? Combined resection and drainage procedures. The commonly done procedure is called as Partington-Russell operation. Simply remember, it is a pancreaticojejunostomy which is longitudinal, where the whole pancreatic duct is open and it is anastomosed to the duodenum or jejunum. Pancreaticojejunostomy. Very few cases total pancreatectomy increase, but ERCP remains the mainstay. If unfortunately it has mainly involved the head of pancreas, then we have no choice except to go for Whipple's procedure. Whipple procedure is a major procedure with a high mortality and these days avoided for this chronic pancreatitis. Remember, Whipple's not a primary choice, it is a must only if whole of the head is involved. So you have to consider what is the resectability. Just remember, what is the Whipple's procedure? Whipple's procedure is a radical pancreaticojejunostomy. What are you going to remove here? Carcinoma head, pancreas, pancreatic head, duodenum, distal duodenum, portion of jejunum, gallbladder, and distal CPD. We don't remove spleen in this case of Whipple's procedure. Anastomosis 3: choledochojejunostomy, pancreaticojejunostomy, and gastrojejunostomy. And new procedure, that is modification, is called as Longmire's and Traverso procedure, where we are going to preserve the pylorus. So this is in short. There are lot many postoperative complications and they may or may not respond. So complications are delayed gastric emptying, fistula, infection, abscess, and mortality is very high. So now the thought has come. The drug of choice is for chemo is gemcitabine, which gives a very good result. And pylorus preserving pancreaticoduodenotomy (PPD) with modified pylorus is one of the major operations. So just remember, surgery for pancreatitis, drainage and resection. Drainage procedure technically easier, resection technically demanding. Morbidity 2 to 5% very less, mortality is very high 8 to 21%. Adequate pain relief, this resection used whenever we are suspecting carcinoma. Then disease tissue, disease progression continues and occult carcinoma is always a fear. In resection, high mortality, diabetes, though ideal, it is not done commonly. So take home message: for a surgery of pancreas, chronic pancreatitis, it is a drainage procedure and endotherapy should be given preference over the surgical techniques. About postoperative care again, it is a nutrition. Nutrition how? TPN, total parental nutrition. In some cases, you need jejunostomy feeding. That is fluid electrolyte management. We have to prevent the sepsis and octreotide. Post-operatively, octreotide is again playing a major role. On table you have to give and you have to continue for 5 days. So this is we have considered about the management of a chronic pancreatitis. Chronic pancreatitis, first is it is this common causes. etiology, etiolopathology, clinical feature, investigations, and conservative management, operative management. These are the heading for a chronic pancreatitis. After that, we will go for, in short, today we will just consider carcinoma of pancreas. In our next lecture, we will go for the details of a carcinoma of pancreas, of chronic carcinoma of pancreas. To start with, carcinoma pancreas is higher in men. Fortunately for us, it is common in African Americans. And unfortunately, 80% of pancreatic cancers are themselves metastatic at the time of first diagnosis. What this means? Most of them are stage 4 cancers. It is common in Jewish and Hawaiians. Its incidence is 9 cases per 1 lakh patient, 1 lakh cases. The age is 60 to 65 years. Not very common, but in our country now it is getting equally common because etiology is changing. The dietary habits, food habits, everything is changing. So, what is the etiology of this? Because we are finding more patients in our country is smoking, acute pancreatitis, gallstone disease, chronic pancreatitis, alcohol, carcinoma of the pancreas, it is smoking. So these are the major etiological factors. And unfortunately, all of them are common in men. Men means man. MEN is different. Okay, we'll discuss afterward. Second cause is high energy diet rich in fat. This is the change of diet. Third cause is chronic pancreatitis, familial pancreatitis, diabetes mellitus, and benzidine like carcinogens which are also available or we are ingesting because of food. Pancreatic calcification, cirrhosis, and obesity. Obesity is also one of the cause for carcinoma pancreas. Occupation exposure like DDT, rare causes. But remember, one of the major cause or one of the etiological factor is previous cholecystectomy. We are very commonly doing cholecystectomy for most of the gallbladder pathologies, and unfortunately, this is considered one of the cause of carcinoma of pancreas. Second is mutation. Simply remember, it is a genetic mutation and the genes are called as KRAS gene for carcinoma of pancreas. Another condition which you many times remember or must know for a short note, Peutz-Jeghers syndrome. This condition is very common for causing number of conditions. We will consider as a short note. FAP, very common cause for any carcinoma, that is familial adenomatous polyposis. FAP is a genetic cause for many of the malignant conditions. Where does it commonly occur? This malignancy occurs commonly in head and neck region. Most common. In head and neck region, which region? Ampullary and periampullary 70% and body and tail 30%. That means this cancer is more common in head and neck region. So which is commonest? Commonest is a periampullary carcinoma. This we must discuss in detail. Why it is a periampullary? It is a tumor arising at or near the ampulla of water. Apart from that, it could be adenocarcinoma from head of pancreas close to ampulla. It is 50%. Tumor arising from ampulla of water, 30%. Distal bile duct carcinoma. These are the different carcinomas which are clubbed into periampullary carcinoma, 10%. And duodenal carcinoma per se, which is nearer to the ampulla of water, is 10%. So, periampullary carcinoma are of 4 types. Head of pancreas, tumors of ampulla of water, bile duct distal cancers, and nearer duodenal cancers. So they combinedly form periampullary carcinomas. So what are the pancreatic tumors? This is a very big term. Pancreas contains many things. So how are the pancreatic tumors are? First, 90% of the pancreas is exocrine. That means they can be exocrine tumors. Pancreas also contain endocrine glands. That means they can be endocrine tumors, and they also consider epithelium lining over the this pancreatic duct, so they can be cystic neoplasm. So pancreatic tumors are exocrine, endocrine and cystic. The most common is exocrine, and which is most common type is adenocarcinoma. So if anybody asks you what are the pancreatic tumor commonest, it is exocrine adenocarcinoma is the most common type. Commonest site, head of pancreas. Other sites okay, periampullary, body and tail. Prognosis, very good for periampullary cancer and worst for body and tail. Again, risk factors, tobacco, genetic, chronic pancreatitis, diabetes, obesity. Again, Peutz-Jeghers syndrome, BRCA2 mutation. BRCA2 is common for which male condition malignancy? It is common for male breast cancers are common in BRCA2. KRAS mutation, and what are the markers? If somebody asks you, best tumor marker for carcinoma pancreas is CA19-9. This will be available in few conditions. This is the best tumor marker. So, if you consider periampullary cancer, what is this periampullary cancer? This tumor in region of ampulla, lower CBD and duodenum. Most common presentation of periampullary cancer is painless jaundice. You must remember number of signs for this. This is very commonly asked. The commonest presentation is, must know is Curvajer's law. This Curvajer's law states that in obstructive gallbladder palpable, that means in a case of obstructive jaundice and gallbladder is palpable, you must suspect periampullary malignancy. This is a Curvajer's law. Never forget this. Fortunately, this periampullary has got a better prognosis. What is IOC? That means investigation of choice for a periampullary cancer is triple phase CT scan. What is ARCP sign? ARCP sign is double duct sign. What is happening here? It is a feature of ARCP in carcinoma head of pancreas. What is happening? There is a gap, that is separation from CBD and pancreatic duct. Ideally, they travel for a terminal distance by the side of each other. So they are separated from each other due to what? Due to the lesion into the carcinoma head of pancreas. This is a very short picture which shows all of the malignancies of pancreas. I will just read name of all these, and in our next lecture we will consider different type of malignancy. So common sites, you start from the most common endocrine tumor. Commonest endocrine tumor is gastrinoma. Other tumors are cystadenoma. Where they occur? They occur in the head. Carcinoma head of pancreas also occurs in the head. Somatocytoma, that is PPMA, occurs in the head. These tumors penetrating, this is important, always remember, pancreatic trauma is one of the major cause. So they can form a cyst or major problem. They are pancreatic penetrating trauma. Pancreas is sustainable to penetrate trauma as well as blunt trauma. Blunt trauma in the neck, blunt trauma can occur in the head, neck, body or tail. Mucinous cystadenoma. This is where the carcinoma grows to very large size. This occurs in body and tail. Viapioma, tail. Glucagonoma, body and tail. and pseudocystal pancreas is more common in body and tail. So these are the common types of tumors. And insulinoma, these are the endocrine tumors. They occur in head, body and tail. They have got a different type of distribution. So this is in short just to remember the names of different malignancies. So how it is going to spread? Three type of spread. Local spread, that means to the adjacent region like duodenum, portal vein. Common in carcinoma head of pancreas whenever the size of tumor increases by more than 3 centimeter in size. Less than 3 centimeter, there is less chance of local spread. So, how does this spread occur? Perineurals, that means among the sheath of a nerve. Nodal spread going to nodes like CBD nodes, subpyloric and celiac. Distant, where they will go? First is liver metastasis, lung metastasis, adrenals and bone. Why liver always common? Because this is going through SMP. The drainage of pancreas goes first to the liver. So what are the clinical features? Ampullary tumors present with jaundice and weight loss. So far we have considered different type of common etiology of a malignant tumors. So you remember that figure of where the carcinoma is occurring. In our next lecture, we will go for clinical manifestations of a carcinoma pancreas as well as the endocrine tumors of the pancreas. Thank you very much. Good day.